Our session by two lectures. The first by Professor Ashraf. He discussed the overall magnitude of the problem of dialysis, and Professor Samir discussed the quality assurance of the hemodialysis service, and we touched the severe limitations in our countries in Africa regarding the facilities and the costs. And today we are discussing a rare situation, or specific situation, which is rarely occur in dialysis, which needs more effort and more cost. In our agenda, in our way, we will have several stations. We will start with introduction, important points to remember, acute kidney injury and dialysis, chronic kidney disease and dialysis, and dialysis prescription, and then we will end with our conclusion. To start with, pregnancy in women with advanced chronic kidney disease or end-stage renal disease is a rare challenging clinical scenario with significant maternal and fetal morbidity. Conception rate in these women undergoing long-term dialysis have been estimated to range from 1 to 7% of women. Recently, the relationship between dialysis intensity and outcome has become clearer, with increased dialysis delivery becoming the standard practice, providing superior fertility and outcome. Recent reports suggest that the result of these pregnancies increased significantly over the years, with having a higher percentage of live births, progressing from 23% in 1980s and 1990s and approaching 80 to 70 to 90% in latest years. We have several reports from Europe, Saudi Arabia, United States, Japan, and even Brazil. But we should put in mind that there is some bias in reporting these publications, because we are dealing with a rare situation, and the successful events, we want to report the successful events. On the other hand, we are not reporting the unsuccessful reports. On the way, we have important points to remember. I will go fast with some of these points, and I will slow down in others. As Professor Said said, the reproductive and sexual dysfunction in women have been affected at several levels. We have decreased kidney prolactin clearance in advanced chronic kidney disease. In spite of having luteinizing hormone, we have absent luteinizing hormone surge leading to an ovulation even with preserved menstrual cycle. We have low level of estrogen and progesterone. We have abnormalities in endometrial morphology. We have dysregulation of the menstrual cycle leading to amenorrhea by the time the patient reaches end-stage renal disease. In spite of this, pregnancy might occur. Another important point to remember is the causes of acute kidney injury. And the most common cause of acute kidney injury during pregnancy is pre-renal due to hyperemesis gravidarum or vomiting from acute pyelonephritis. We have pregnancy-specific conditions, we have obstetric complications, and we have obstructive uropathy. The pregnancy affects kidney disease adversely. It can cause worsening proteinuria, loss of kidney function, and hypertension. On the other hand, the kidney disease affects pregnancy in the form of infertility, preterm delivery, and other complications, as Professor Said said. We don't have a validated classification of chronic kidney disease in pregnancy. We don't have validated definition of chronic kidney disease, but this classification is based on the level of serum creatinine, classified into mild and moderate and severe chronic kidney disease, which, based on the difference between these category levels regarding CKD progression, maternal and fetal outcome. In mild chronic kidney disease, we may have less than 10% decline in renal function, which increased to 30% in moderate chronic kidney disease. And even if the blood pressure is not controlled, we can have more than 50% decline of glomerular filtration rate. And we may find 10% progression to end-stage renal disease within 6 to 12 months after delivery. In severe chronic kidney disease, the progression to end-stage renal disease is high. We should note that the outcome percentage in all stages is highly affected by the level of control of hypertension. And this is the effect of chronic kidney disease on pregnancy. When we have mild chronic kidney disease, we have a more than 90% live births in women, which decreases to 85% in moderate chronic kidney disease, but we still have 60% prematurity. In marked degree of chronic kidney disease, the fetal losses is very high, but the real estimate is uncertain. Again, the outcome percentage in all stages is highly affected by the level of control of hypertension. As Professor Said said, it is a multidisciplinary team: nephrologist, obstetrician, nutritionist, and the neonatologist, and we should not forget the lady and her family. So, preconception counseling is very important. We should discuss with the lady the potential maternal and fetal risk. So, counseling all women of childbearing age with CKD or end-stage renal disease regarding pregnancy options and contraception is important to avoid unplanned pregnancy or pregnancy with poor antenatal care. Of course, deferring pregnancy until renal transplant is achieved, as Professor Said said, is the ideal option, although complications remain high. However, there is a consideration here. Given prolonged waiting time for organ transplantation, this may occur after the reproductive years have passed. So, with improvement of outcome, with intensified dialysis, there may be a shift in the way women are counseled regarding pregnancy on dialysis toward a less discouraging attitude. We discussed before by Professor Said the obstetrician perspective, and I'm discussing now the nephrology perspective, but we are ignoring the woman perspective regarding pregnancy on dialysis. And this very nice paper discussed this issue. We can find the strong motivation of the ladies to become a mother, but this is counteracted by the fear of birth defect, the fear of exacerbating renal disease, and even inheritance of some renal disease. So these women suffer from decisional insecurity and conflicts, and so we should support these ladies regarding this decision. There is some counseling tips for dialysis or pre-dialysis patients who wish to undertake pregnancy, and this is a nice study, best practices on pregnancy on dialysis, the Italian study group on kidney and pregnancy. They suggested that counseling on pregnancy and contraception should be included in the whole approach to all women in childbearing age or start dialysis, but not graded. Residual kidney function and normotension are favorable prognostic factors, again not graded. Counseling should also include the fact that outcome of pregnancy are better after transplantation. They suggested that the main risk factor for the child are those linked to prematurity, but they didn't find an increase in congenital malformation in their report. But again, we should remember that we don't have an evidence-based medicine regarding this issue, because we don't have controlled trials, which is not feasible in this situation and not ethical, and these reports have some bias in reporting. And this is the available CARI guidelines for pregnancy and chronic kidney disease. Pregnancy and chronic kidney disease, not pregnancy on dialysis. These are the Australian guidelines. They suggest that women with mild chronic kidney disease with normal or near normal glomerular filtration rate can be allowed to get pregnant so long as the hypertension is well controlled. On the other side, patients with marked chronic kidney disease should not be allowed to get pregnant. But we should remember that even those patients with early chronic kidney disease have a two-fold higher incidence of complication when compared with women without chronic kidney disease. Of course, these women should be evaluated thoroughly and their medication to be reviewed before allowing to get pregnant. Another important point on the way is the diagnosis of pregnancy and dialysis. The diagnosis of pregnancy may be difficult, and the presence of the fetus and the gestational age should be verified by ultrasound examination. Again, this is not graded. The diagnosis is difficult because pregnancy is often unexpected, and the symptoms in the early phase may mimic different diseases and complications of dialysis. And moreover, the serum level of beta-human choriogonadotropin may be increased even in absence of pregnancy. In this context, early ultrasonography should be used to verify the presence of a viable fetus and to calculate the gestational age. Another important point to remember is superimposed preeclampsia. And again, the diagnosis of superimposed preeclampsia in chronic kidney disease pregnant women is difficult. Why? Because our patient already has renal impairment with or without proteinuria, with or without the absence of significant urine output if late stage of chronic kidney disease or stage 5 CKD. We have high blood pressure, low GFR, high serum urate, and increased urinary protein excretion, which could be due to progression of renal disorder rather than superimposed preeclampsia. So, we have to suspect preeclampsia when we have an unexplained rise in blood pressure, not responding to fluid removal and drugs, when we have classic preeclampsia symptoms such as visual abnormalities, severe headache, epigastric pain, and hyperreflexia. On the other side, when we have fetal growth restriction and abnormal umbilical artery blood flow, and when we have laboratory abnormalities consistent with HELLP syndrome and thrombocytopenia. In the near future, there may be a chance for the serum biomarker for diagnosis of superimposed preeclampsia. They can define the presence of placental abnormality or endothelial damage, but is not routinely utilized in our clinical practice. Another important question on the way, when to initiate dialysis. Professor Shaisha said yesterday, we should not manage the patient as numbers. We are managing a human being. Some recommend to commence dialysis at estimated glomerular filtration rate 20 milliliter per minute, blood urea nitrogen 50 milligram per deciliter, and serum creatinine 3.5 to 5 milligram per deciliter. They are aiming for a better outcome of pregnancy. But this Italian study group discussed this issue in a more wise way. Initiate renal replacement therapy with a good metabolic and fluid balance cannot be achieved by conservative treatment, and this is not graded. And when deciding to start renal replacement therapy, we should consider the presence of conditions that can be modified by dialysis, the trend of the patient laboratory tests, I mean the pattern of decline of renal function, and control of hypertension and fluid removal, and the fluid overload removal rather than creatinine-based threshold alone. We have to consider urea level in the decision when to start dialysis. The blood urea nitrogen test can be considered a very important marker of outcome when dialysis is already initiated. Again, we should stress on that there is no threshold has been established for dialysis start. We should consider the phase of pregnancy in the decision. We have to balance the risk and benefit of dialysis start versus early delivery in late pregnancy. Suppose we have a lady at the 28th week, we can initiate dialysis if indicated in order to give more chance for the baby to be more mature. While those after the 34th or around this gray area 34th gestational week, we can sometimes postpone in order to avoid preterm delivery. And in some situations, low protein diet may be useful or postponing dialysis in selected cases with advanced chronic kidney disease. Again, the last point to remember on our way is the indication for delivery in women with preeclampsia or chronic kidney disease when we are unable to control hypertension, when we have deteriorating glomerular filtration rate with no reversible component, when we have neurologic abnormalities, worsening thrombocytopenia, increased level of transaminases, and of course failure of fetal growth. We will go to another station, acute kidney injury and dialysis. Unfortunately, we don't have a validated definition of acute kidney injury on dialysis, but I will focus on the characteristics and outcomes of acute kidney injury treated with dialysis during pregnancy and the postpartum period. Here in this study, they compared two groups of patients, acute kidney injury patients treated with dialysis and other group, big number, without acute kidney injury. And here you can find that we have a significantly higher distribution of age in the group with acute kidney injury treated with dialysis. We have significantly lower socio-economic standard, and we have more medical complication and pre-existing chronic kidney disease. And the number of patients of the group with acute kidney injury treated with dialysis has a very lower incidence rate of referral to nephrologists. Here you can find a lot of complication among this group with acute kidney injury treated with dialysis. We have more diabetes, preeclampsia, thrombotic microangiopathy, etc., pyelonephritis, and preeclampsia is the leading cause of maternal morbidity and mortality. The incidence of 90-day maternal mortality is high in acute kidney injury treated with dialysis, about 4.3%, and we have 4% remained on the chronic dialysis. And this is the adverse perinatal outcome in the form of low birth weight, small for gestational age, preterm births, stillbirths, and others. Other destination is the chronic kidney disease and dialysis. In order to focus on chronic kidney disease and dialysis, I prefer to compare pregnancy outcome, as Professor Said said, according to dialysis commencing before or after conception in women with end-stage renal disease. And in this study, we compared two groups of patients. Group who has conception before dialysis. Usually, dialysis starts 3 months after conception. And the group conception on dialysis, pregnancy occurred after a mean of 11 months of initiation of dialysis. We can find here that group with conception before dialysis has a significant lower age distribution than the other group, and it has a higher estimated glomerular filtration rate at commencement of dialysis. We have here the incidence of live birth rate is high in the group with conception before dialysis than the other group, while the incidence of spontaneous abortion is higher in the group who has conception on dialysis. The distribution of gestational age and birth weight did not significantly differ between the two groups. The mode of dialysis is not different, whether they were maintained on the peritoneal dialysis or hemodialysis. In this regard, the Italian study group on kidney and the pregnancy discussed this issue, and they suggested that in patients already on dialysis when the pregnancy starts, dialysis can be continued in the same mode, provided that a good dialysis efficiency is reached. For patients who need to start dialysis when the pregnancy is underway, we have to consider the patient's preference, the phase of pregnancy, the expected dialysis efficiency, the availability of intensive dialysis, and the risk of rapid loss of kidney function. As Professor Said said, the residual renal function is important, and peritoneal dialysis, as you know, can preserve the residual renal function more than the hemodialysis. But even this point, which is in favor of peritoneal dialysis, should be evaluated. And because some patients with chronic interstitial disease seems to progress very slowly than other causes of primary or secondary glomerular disease. So the selection criteria between hemodialysis and peritoneal dialysis is not simple, and it may need wise decision. Another important point to focus on is the intensive hemodialysis. Intensive means increased duration and the frequency of dialysis, which is associated with improved pregnancy outcome. And this nice paper compared the Canadian and United States cohort. The Canadian group dialyzed patients for 36 hours per week, while the United States afford dialysis about 26 hours per week. And here you can find that the live birth rate is significantly higher in the Canadian group, and the gestational age is significantly higher, and there is a very good dose-response relationship with increasing the number of hours per week dialysis for the patient. We have a significant higher incidence of live birth rate. We have a significant higher incidence of gestational age and birth weight. And this is another studies from Singapore, France, Italy, and Canada confirming this issue. Another point is the dialysis prescription. Of course, the dialysis prescription target is to achieve a successful delivery. We have several protocols applying for this. This is the Toronto Pregnancy and Kidney Disease Clinic protocol. They are stressing on fetal assessment and follow-up, as Professor Saeed discussed before. Discussing the vitamins and mineral and diet, electrolytes, bone health, anemia, volume status, and hypertension. We can afford double dose of vitamins. We can give folic acid 1 to 5 milligrams per day. We have unrestricted rich protein diet. We can give up to 1.8 gram per kg per day. And this is another protocol. The Italian study group on kidney and pregnancy discussing the same issue in different way. We have the blood pressure control, of course. We have to achieve a target less than 140/90. To maintain medication to avoid diuretic is inherited at ARBS. The preferred medication besides dopa, labetalol, nifedipine, nicardipine, and verapamil. We have to intensify the dialysis treatment. We have to avoid acidosis. We can give calcium supplement. We should correct anemia. We can double the dose of erythropoietin. We can give iron, either oral or intravenous. And this is the effect of the dialysis prescription in the form of duration, frequency, and efficacy with lower percentage of polyhydramnios. Here there are several points. Dialysate potassium. The potassium concentration in dialysate must also be adjusted to reflect the more intensive hemodialysis regimen, usually with a concentration of 3 milliequivalent per liter. The dialysate sodium we should reduce to 135 millimole per liter in order to meet the reduction in serum sodium during pregnancy. Dialysate bicarbonate usually reduced to 25 milliequivalent per liter. Dialysate calcium, we should increase dialysate calcium to 1.75 to 2.5 millimole per liter. We can give oral calcium supplement. Pre-dialysis and post-dialysis calcium level should be measured to avoid hyper and hypocalcemia. Heparinization should be minimal to prevent obstetric bleeding. It is safe to use heparin whenever there is no vaginal bleeding. We should change the cycle function of the vascular access in order to reduce the risk for vascular access dysfunction. We can use the rope laser technique. We have to assess ultrafiltration and dry weight assessment. We should monitor the clinical signs of hypervolemia, blood pressure out of target, respiratory compromise. Edema is an unhelpful sign in pregnancy. We can monitor hematocrit and albumin level, measuring hematocrit and albumin and the initial first trimester visit. A rise in either value strongly suggests intravascular volume contraction, but the opposite is not true. And this is the best practice on pregnancy on dialysis, discussing the diet and weight management. The patient diet should be unrestricted and rich in protein, supported by several experts but not graded. Phosphate supplement may be needed on long-hour daily hemodialysis. Soluble vitamin level should be controlled and supplemented when needed. Weight gain should be carefully monitored, trying to avoid dehydration and hypotension. The weight gain is estimated at 0.3 kg per week during the second trimester and 0.3 to 0.5 kilogram per week in the third trimester, but not graded. And this is the dialysis schedule for hemodialysis. Hemodialysis is the standard extracorporeal treatment in pregnancy. There is no difference between conventional hemodialysis and hemodiafiltration. We have to intensify the dialysis afforded for the ladies to at least to 36 hours because we will increase the probability of success of baby survival to more than 85%. They recommend adapting the prescription of bicarbonate, potassium and calcium to the individual patients. They do not recommend using KT over V or equivalent renal clearance as a measure of dialysis in pregnancy due to the lack of studies validating these methods. But they can depend on the level of blood urea nitrogen less than 50 milligram per deciliter or urea level less than 100 milligram per deciliter, which could be used as a surrogate but not graded. There is no evidence that any type of peritoneal dialysis is superior to the other. The treatment of anemia, as Professor Saeed Abdelhadi said, is very important because anemia is linked to fetal complications. Anemia should be managed with erythropoietin stimulating agents and vitamins. The hemoglobin target should be 10 to 11 grams per deciliter. Even doses frequently need to be increased in pregnant dialysis patients. The demand of iron is increased in pregnancy in dialysis. Oral iron is safe in pregnant women on dialysis, while intravenous iron should be managed with care in dialysis mothers, especially in the last trimester, because it might be deposited in the fetus tissue. Folate and B12 supplementation should be tailored according to blood level, but again moderate. Vitamin D supplementation is safe in pregnancy and may be required at increased doses. Calcium-containing phosphate binder are safe, while Civilever, Renagel may negatively affect fetal ossification. This is evidence from animal studies. Special attention should be also paid to magnesium levels, since low level may favor uterine contraction. So we have to keep the serum magnesium level between 5 to 7 mg per deciliter. And this is the most commonly used antihypertensive medications used during pregnancy on dialysis. And regarding the control policies, they recommend strict clinical control for all patients. The frequency of visits should be personalized. They do not suggest preemptive hospitalization except for obstetric-related reasons. Obstetric and nephrological visit should be combined to minimize stress on the patient. Here you can see from these discussions that the multidisciplinary approach is very important in this situation. We approaching our destination, we can conclude that intensive hemodialysis might improve fertility along with maternal and fetal outcome, but require careful follow-up and management from a multidisciplinary team that includes nephrology professionals working closely with professionals from obstetrics. Pregnancy during dialysis is still a challenge to get there, but worth the effort. Improved outcome for women with CKD who commence dialysis in pregnancy, as well as the growing body of evidence regarding intensive dialysis regimen to improve outcome. There may be a shift in the way women are counseled regarding pregnancy on dialysis toward a less discouraging attitude. I do recommend to revise and read these best practices on pregnancy on dialysis, the Italian study group on kidney and pregnancy, not only because it contains a lot of information, but it also increases the scope of our vision and make us think in a more wise way. Thank you for your attention.
Thank you very much, Professor Fouda, for this presentation, and I invite you to join us for the discussion. Questions?
Thank you very much for those two presentations, which are very important for us, because our patient dialysis, we have young patients who are sexually active, so that they can have pregnancy, they can be pregnant at the moment. But here what I want to say is according to what the problem is found for those patients in countries, I don't know if they sell with others, is that you cannot do intensive hemodialysis according to the means. They don't have means to pay to be followed correctly. And in that case, I see that we have to do preconception counseling, a good way for them. In other cases, even they have a good preconception counseling, they can become pregnant. So, in what you said, I don't see anyway if we can interrupt pregnancy for those patients. Is it indicated or no? Because we see that pregnancy has many side effects on the mother, and the prognosis for the baby is not good, but the mortality is very elevated. So, for you, according to your experience, have you just tried to interrupt pregnancy for those patients?
Yeah, thank you very much. The question of termination of pregnancy should be calculated quite well, based on several factors. Number one, the kidney function, the level of hypertension, and the availability of proper hemodialysis. I think these three factors are the determining factors. I don't know the comment of my colleagues, but in this country, I think I've seen about 20 and 15 patients with renal failure on dialysis. But the majority I see now are following renal transplant, which are doing okay. This is not your question. But your question is, I've seen just one patient who was above 40, with blood pressure above 160/100, and for that patient, she already had babies, and the decision was quite easy to terminate pregnancy. The young lady I presented, she was just 19, 20, so we carried on. We increased the number of dialysis to every single day, or at least 5 days. The total hours, 20 hours, which is quite feasible and available in this country. Her blood pressure was 140/90, so we counseled her regarding the risk, and the patient accepted to carry on, and so we carried on. But as a physician practicing, you need to calculate the risk for the patient and your availability of service. If you don't have the facilities to increase the number of dialysis hours to 20 hours, if the blood pressure, the starting point is high, above 140/90, if the creatinine starts with, of course creatinine will come down from dialysis, but if there is no renal function at all before our early pregnancy, then you have all justification to terminate. So there is not a single clear-cut value, but there are definitely in the textbooks an indication for termination, which I just mentioned. And this depends on the availability. Even with the best service, with the availability of hemodialysis, with the availability of very good physicians and obstetricians and neonatologists and the whole team of the medicine team, yet the prognosis is not good. Okay. Thank you very much, Professor Fouda.
I started my talk, I said that I am discussing the extreme side. We are discussing the facilities, the cost, the expense, the availability of machines and so on. And then I'm discussing rare clinical scenarios like these pregnancy or dialysis. So we should individualize our decision regarding this. We have to, when we are facing a lady with, she has several kids, there is no need to expose her to the risk of maternal complication. But sometimes we have a precious pregnancy. Sometimes you have to support this lady, so long as we have the facility, so long as we have reasonable residual renal function, so long as the blood pressure is well controlled. I have the facilities to afford for her intensified dialysis in order to give her the chance of getting a mother. Of course, the ideal option is to wait for transplantation, which is not an option for all ladies. So, as Professor Said said, we have to select our patients. We have to individualize our decision according to this, because we don't have a quantitation of the risk except the residual renal function and the normal blood pressure.
If you allow me, there is an absolute indication for termination of pregnancy, and this is from the obstetrician perspectives, like intrauterine fetal death. And I stress upon the statements of Professor Fouda about the humanity of the decision. Sometimes you find the lady insisting to continue pregnancy. So at the end of the day, it is not the decision of termination of pregnancy. It's not obstetrician decision, it's not nephrologist decision, it is the decision of the all nephrologist, obstetrician, and the lady. And my question to Professor Said, what are the absolute indications for termination of pregnancy?
Yeah, for termination of pregnancy is still the same. If you have a blood pressure, the three main parameters that we take it seriously is number one, the age of the patient, the number of living children, and that makes the decision to terminate easy if there is any of these. Number one, blood pressure above 160 over 100. So that makes the decision easy if you add to the other factors. Number two is the poor kidney function to start with early in pregnancy or the start when you see the creatinine is hanging above 4. Usually they say, we sometimes say 4.5 to 5, but we usually take 4 as a good marker that if these two are there, added to the other variables, then we terminate to start with very early in pregnancy in the first trimester. But we can terminate at any time if we think that the fetal growth is compromised, there is evidence of severe IUGR, or marked elevation of blood pressure, or starting deterioration of other organs like HELLP syndrome or severe preeclampsia. So down the road, there are also severe complications that we can terminate pregnancy. So the answer is individualized, but at any certain point, we can terminate pregnancy. As we say, if it's early pregnancy, we look at the age, the blood pressure, and the serum creatinine. Down the road, if there is any evidence of compromise on the liver function, on the blood pressure, and sometimes we go in heart failure during the pregnancy, all this kind of thing we can terminate. And definitely if the growth of the baby is markedly compromised. So sometimes a clear-cut decision to terminate, but in the majority of cases, it is a dialogue between the physician and the patient. Thank you.
Yes, please.
Je vous remercie infiniment, excellent professeur, de cette très belle présentation qui nous ont donné beaucoup d'informations et beaucoup de précautions en matière de prise en charge des patients hemodialysés ayant le besoin de conserver le grossesse. Dans mon centre de hemodialyse à Moroni, qui a presque 6 ans depuis son ouverture jusqu'à aujourd'hui, j'ai eu difficilement à gérer 2 cas qui ont refusé d'utiliser le préservatif et qui ont dit que vraiment il est impossible parce que nous avons besoin d'avoir des enfants. Quel que soit, il faut que nous ayons des enfants parce qu'on vit en couple, en mariage. Donc on était obligé de céder, mais finalement la première femme a eu un enfant prématuré de 28 semaines, puis qui a décédé. Parce que la prise en charge chez nous est très basse, surtout chez les nouveau-nés. On n'a pas une pratique technique vraiment suffisante. Deuxième cas, c'était l'autre femme. Elle a échoué une fois avec un avortement, mais elle a tenté et finalement elle a pu arriver à accoucher un enfant normal vaginal délivré. Donc l'enfant est bien actuellement, l'enfant a 2 ans. Mais qu'est-ce qui s'est passé? Nous avons constaté que la femme après l'accouchement elle a développé une sténose centrale, central sténosis. Et j'ai envoyé les photos au professeur Hussein Checham parce que la femme avait une œdème très massive au niveau du membre supérieur gauche, là où il y a la fistule. L'œdème a envahi la partie gauche jusqu'à atteindre le sein plutôt. Donc vraiment nous avons eu peur parce qu'il y avait la tendance d'exploser un jour. Il y a eu aussi une fois qu'il y a eu des infections au niveau du membre supérieur. Donc j'ai eu peur, j'ai tapé toutes les portes, j'ai même envoyé le rapport au centre de Mansoura, professeur Checham, afin de pouvoir trouver une solution avec les chirurgiens vasculaires en Égypte. Mais finalement, la patiente s'est débrouillée pour aller en territoire français. Et là, justement, on a greffé des veines, on a fait des chantes et des greffes. Donc, il y a 2 mois, la femme est de retour. J'ai voulu poser ma question sur s'il y a une corrélation ou une relation entre ce sténose central et la grossesse. Et je vous remercie.
Thank you very much for those who are waiting for translation. He discussed 2 case scenarios. The first case scenario, the lady who was keen to get pregnant while on dialysis, and she declined the advice to avoid pregnancy, and the inevitable event is she got a preterm labor, market preterm, around 28 weeks, and the baby died. The second case scenario he mentioned is a lady who also was keen to get pregnant. She had first a miscarriage, but the second pregnancy she managed to get pregnant and delivered a live-born baby who is doing fine at 2 years, but the lady herself developed massive edema of one side as a result of other side of the arm fistula, and she went to France. She had multiple grafts and she is back. So in both situations there was a catastrophe, and the first the baby died, and the second the lady was about to die. Is this correct, sir? Is this correct what I just said? It's fine. So your question is regarding the fetal side. It's quite common. The case I presented is very similar to what you say. Although in this country we can control the kidney, the dialysis quite well, we can increase the number. We usually say 6 times, 5 to 6 times a week, not less than 20 hours. It's fine. We did all this, and yet the patient ended in a miscarriage around 24 weeks, and the baby died, exactly as you said in the first page, which is common. And also remember that the underlying disease which causes renal impairment or renal failure itself affects the pregnancy. So we see many patients on systemic lupus or lupus nephritis, or even lupus antibodies, which develop very serious obstetric complications while the kidney function is fine. So just the lupus antibodies can have adverse effect of pregnancy. So it's quite clear that the baby prospect is bad. For the second lady, she's delivered vaginally. In my situation, if the growth of the baby is compromised, or if the blood pressure is high, we prefer for this very high risk woman to deliver by cesarean section, where we control things in a better way. You decide the time, you select the best anesthesiologist. You more or less go in an elective situation rather than allowing a hand to go and deliver it. Does delivery affect the arteriovenous fistula? What happened after delivery is the blood going to the uterus is suddenly reduced, and this goes back to the heart. So patients, usually in cardiac patients, we used to see heart failure immediately after delivering the baby or delivering the placenta, simply because the blood flow going to the placental circulation is about 600 mL per minute. So this will be redistributed. Can this be the cause of the massive edema? I really don't know the answer. But what we used to see more common is thrombosis following delivery, deep vein thrombosis, and this could occur in the arms or in the legs as well, or in the veins of the limb. So, to answer your question short, yes, it's possible through either an increased flush of blood or more commonly development of thrombosis in this vein. And both could be explained by the effect of pregnancy. Yeah, thank you very much.
Thank you so much for your two cases of clinical scenario. The first case, we are facing such a case every now and then. And I said we should not forget the patient preference, the patient's opinion regarding the desire to get pregnant or to continue pregnancy, and we should not do anything against the will of the patients. And so this is a common clinical scenario. In spite of the facilities and in spite of affording even the best service for her, you can face this situation. Regarding the second, as we know, there is a state of hypercoagulable state during the pregnancy. And this hypercoagulable state can increase in the presence of some original kidney disease causing end stage such as systemic lupus and other immunologic parameters. That is why we are affording heparin and aspirin for our patients, but I'm not sure that this catastrophic situation after delivery is related to this or related to another mechanical cause regarding the fistula. I don't know. But I think the vascular surgeon will take the upper hand in deciding the possible cause of this situation, so long as we don't have a full details about the original kidney disease, whether these patients suffering from lupus or not. And I think the vascular surgeon will help us more.
Merci beaucoup. Pour moi, ma question est vraiment simple. Je voudrais juste savoir, parce que je vois que chez la femme enceinte, elle est presque obligée de passer tous les jours dans le centre de dialyse. Parce que 6 jours par semaine, c'est presque toute une semaine et toute la vie pendant la grossesse. Et je voudrais savoir, quand une femme développe une insuffisance rénale aiguë, est-ce que c'est la même prise en charge? C'est ça ma question.
Yeah, fine. The question is more for a nephrologist, but he says 20 hours a week or daily dialysis is quite too frequent. The other question is, what about women who develop acute kidney injury during pregnancy? Do you still go for the same? I'm just saying, we used to say, I'm speaking about the obstetric point of view, we see acute kidney injury more common than chronic kidney disease. And all these are obstetrically related rather than kidney related. I mean, there are so many severe complications of pregnancy that end in acute kidney injury. We mentioned severe preeclampsia. We mentioned eclampsia when the woman gets eclamptic fits. We mentioned HELP syndrome, that's hemolysis elevated liver enzyme and low platelet count as a complication of many diseases. We also see massive hemorrhage as either antepartum hemorrhage or postpartum hemorrhage, and in this situation we go into acute kidney shutdown or acute kidney injury. So we are more aware of the acute kidney injury during pregnancy than the chronic injury. And it is quite common practice to take the patients after being stabilized from the obstetric ward to the hemodialysis when they have renal disease. But the indication of dialysis are exactly the same. Okay? You take the creatinine level, the potassium level, and the kidney perfusion as a marker. So yes, we see acute kidney injury more common. This is a common practice on an everyday basis, and we follow the same line. So once creatinine starts rising, usually there is hematuria or evidence of rising proteinuria nitrogen, increasing potassium level. This is going with the amount of urine and creatinine clearance. All these indications are exactly the same as in the non-pregnant state, and the patient is managed exactly on the same route. We just say in obstetrics, if the patient develops renal failure, you need to terminate pregnancy. So once we terminate pregnancy, it takes a short time and then the prognosis is okay. So most cases of acute kidney injury during the pregnancy are curable with termination and short periods of dialysis. To the best of my knowledge, there's just one patient who needed dialysis for more than 1 month, but the majority of the patients may need dialysis for a week or 3 days or so. Once you terminate pregnancy, the disease subsides and the patient recovers very fast.
The management of acute kidney injury with dialysis depends on the clinical situation of the patient. On chronic kidney disease, on dialysis, we are managing a stable situation, but in acute, I am aiming to preserve the patient environment, the patient life. Most of the reported series of managing acute kidney injury with dialysis is ICU patients. And they are managing these patients with slow continuous therapy, not with conventional hemodialysis, except in some specific situations where the hemodynamic parameters can allow for this. So the primary target here is the patient, not the pregnancy in acute kidney injury necessitating dialysis. But as Professor Saeed said, you can have acute kidney injury in a stable situation. You can dialyze the patients whenever indicated, not in a regular basis. And then we can follow if this acute kidney injury is expected to recover soon, or if we have a significant problem in which we will extend the dialysis for 1 month, 2 months, or even 3 months, I can afford for the patients, if I have the facilities, that I can intensify her dialysis in order to keep her clinical situation and the chance for getting a viable fetus.
I want to add just a simple sentence that the presence of acute kidney injury is not an absolute indication for termination of pregnancy. So, as Professor Fouda mentioned, Professor Saeed said that there is no obstetric acute catastrophic problems like eclampsia, HELP syndrome, acute fatty liver pregnancy. And just I have a patient who has, for example, glomerulonephritis or lupus nephritis that's complicated by acute kidney injury. It is better not to be rushing in the decision of termination of pregnancy, because this may be the only chance for the lady to have a fetus. just we monitor to taking care of the patient by doing dialysis when indicated, and supportive treatment and multidisciplinary care approach. So acute kidney injury by itself is not an absolute indication for acute kidney injury, except if it is within the domain of obstetric catastrophes. Please. Yes.
Je vous remercie pour la présentation. Moi, j'aurais une question par rapport à... Ok. J'aurais une seule question à vous poser. En tenant compte de votre expérience personnelle et des connaissances que vous avez par rapport aux données de la littérature, pouvez-vous nous donner le pourcentage des femmes qui ont pu mener à terme leur grossesse et dans les enfants sans aucun problème?
Sorry, he says what is the figure of a sound delivery. I don't know what you mean by sound. Can you just ask him what you mean by sound? Mean vaginal birth or fetal health? What do you mean by sound?
Je parlais de l'accouchement normal.
Vaginal birth. Yeah, in normal circumstances, we do not allow vaginal birth for patients. I totally agree that in these circumstances, it is better to have a cesarean delivery for many reasons. Number one, you control the situation with all the team. And number two, in the majority of cases, over 80 to 85%, the placental circulation and the fetal situation is compromised in a way or other. Number three, there may be one-off situation. This patient may not have a chance to get pregnant anymore. So I think there is a consensus that all patients with chronic renal failure or those who develop acute kidney injury during pregnancy that we need to deliver, we go for cesarean section. And I think that's the consensus from the point of view of most obstetricians.
Yes. Last question.
Merci, cher professeur, pour votre exposé. Je commencerai un peu en donnant un peu nos données. Je suis médecin en néphrologie au CH de Brazzaville. Je peux dire que sur à peu près 10 femmes qui ont eu une grossesse, qui sont insuffisants rénal chronique, au stade sévère ou même terminal, alors sur à peu près 10 femmes, je peux dire qu'au moins la moitié atteignent le deuxième trimestre. Mais en général, sur cette moitié, ça atteint le deuxième trimestre, il y a un accouchement prématuré. Et comme nous n'avons pas l'équipement nécessaire pour prendre ces enfants en charge, ils meurent. Mais je peux dire que, alors, certaines grossesses arrivent à terme. Donc, si on peut dire que sur 10 femmes, 5 ans atteignent le deuxième trimestre, on peut dire au moins 2 vont arriver à terme. Mais sur les 2 qui vont arriver à terme, je pourrais dire que dans la majorité des cas, ils mettent l'enfant au monde et cet enfant meurt en période néonatale. C'est assez rare de voir que l'enfant continue à vivre ultérieurement. Ça, c'est l'expérience que nous avons. Il est rare que ce genre d'enfant atteigne 5 ans, 6 ans, c'est très rare. La majorité meurt dans les 2 premiers mois. Et ces enfants meurent. Mais j'avais une question, parce que chez nous, il y a un problème, je ne sais pas comment ici en Égypte vous faites, pour la coopération entre les néphrologues et les gynécologues. Parce qu'en général, chez nous, il n'y a pas une bonne coopération. Il n'y a pas un circuit de la patiente enceinte qui oblige, par exemple, le gynécologue, quand il a affaire à une patiente insuffisante rénale chronique, de soumettre cette patiente-là au néphrologue. Mais il n'y en a pas. Donc, s'il veut, il a su à sa façon. S'il ne veut pas, là où il peut confier au néphrologue. Alors, j'aimerais savoir, en Égypte, y a-t-il une réglementation qui définit la relation entre le néphrologue et le gynécologue pour les patients insuffisants rénale chronique qui sont enceintes?
Thank you very much. He's asking a very frustrating situation. He says he has followed about 10 pregnant ladies. 8 out of them they delivered prematurely, and 2 delivered even vaginally at full term, but unfortunately the babies died. This is the situation, he says, in Congo. I would say the situation in this country, especially in this city, because we are fortunate having this center, is a bit better. I would be very unhappy if a baby goes into term and delivered vaginally and the baby died. And definitely there is here a question of the integration of the health service. These patients should be admitted around 34, 35 weeks. Now we don't allow pregnancy in this lady to go to term, and we don't, as I said before, allow them for a vaginal birth. Around 34 weeks, if there is gross restriction, we terminate pregnancy. I know the integration between different disciplines in medicine is not the same in every country, but fortunately enough, here we refer this patient to this teaching hospital where all these physicians work together and the decision is taken on multidisciplinary basis. The neonatologist also is consulted and he is advised to attend the delivery so he can receive the baby and work on it. And not full term, but I think safely at 34 weeks we can rescue the baby and we can get a good prognosis. The fact that pregnant ladies with renal, especially chronic renal disease, have complications, and the babies too have complications, but not as grave or not as bad as you just said. In Egypt is more fortunate, as I said, but I would fairly say we have 10 patients, at least 5 out of these 10 will end with a dead home babies, which is, I would say, 50%. And we don't deliver them vaginally, we don't allow them to go to term, and we involve heavily discussions with other physicians. So your circumstances is a bit meaning further development in the multidisciplinary team, and you need to sit together and you need to discuss this with your local health officers and governors and so on. So health care is a circle that if interrupted at certain point will lead to bad consequences in the patient. Usually outside this center, outside this city, in the far areas of Upper Egypt or in Sinai or River, I think we could still end in the same situation as you said. But our experience is about 50% taking babies, and another 50% the baby ends in miscarriage or very early preterm baby, which we cannot do anything for it.
Merci. Je me rejoins aux autres remercier les professeurs pour la qualité de leur exposé. Et la question que je voudrais poser, c'est par rapport aux jeunes femmes en âge de procréer que nous suivons dans nos services pour des insuffisances rénales très modérées, mais chroniques modérées. Est-ce que pour ces jeunes femmes ayant le désir d'avoir des enfants, il ne serait pas mieux de faire une transplantation préemptive que d'attendre qu'elles arrivent à des insuffisances rénales sévères, sachant que à ce moment, si jamais elles contractent une grossesse, il y a quand même tous les risques dont vous avez parlé à travers vos exposés, les risques d'arriver à terme de leur grossesse. Donc, pour moi, pour leur donner une chance, en cas d'avoir des enfants, des femmes qui n'ont jamais eu d'enfants, mais qui ont cette insuffisance rénale chronique modérée, est-ce qu'il ne serait pas mieux de faire une transplantation préemptive? En leur donnant donc, avec la transplantation préemptive, la chance d'avoir des enfants, que d'atteindre le stade avancé de l'insuffisance rénale chronique, où les chances d'avoir l'enfant, les chances sont quand même très très faibles. Voilà un peu ma question. Merci.
Thank you for your very intelligent question. Our colleague is asking about he is facing a patient with chronic kidney disease. I understood that he mentioned mild chronic kidney disease sometimes. But so long as you mentioned renal transplantation, so we have more advanced chronic kidney disease in your patients. And he is asking about, can we proceed for preemptive renal transplantation in order to give a better chance for the maternal and fetal outcome? According to the observational studies and according to the opinion of the expert in this situation, they consider that mild chronic kidney disease having the estimated glomerular filtration rate more than 60 milliliter per minute. If we have this figure with well-controlled hypertension, we can allow these ladies to get pregnant. But if we have a chronic kidney disease less than this, we should explain for the ladies that she has a substantial risk of progression of chronic kidney disease that it can reach 50%. And we can take the decision with her. We will proceed for pregnancy without the need for initiation of dialysis, and we will follow the lady. Whenever we feel that she will need renal replacement therapy, we can initiate dialysis. But there is no way to undertake preemptive renal transplantation on the assumption that she will have a better chance, because there is no guarantee for this successful transplantation is number one. Number two, I prefer not to expose the patients to the risk of immunosuppression. Dr. Hussein discussed yesterday the early initiation of dialysis, and we are discussing even the late initiation of dialysis, and we have several literature discussing the timing of renal transplantation. I can stay until I have a lower creatinine clearance before proceeding to transplantation. So it is more logical not to proceed in such a situation for renal transplantation, just to have a better maternal and fetal outcome.
So if I am confronted by your case, I'll do what you do. I'll do what you did. So long as this is chronic kidney disease in the stage 3, I'll continue the pregnancy, because I don't know what about the future chance of getting pregnancy. But I should discuss with the lady. We have low risk, intermediate risk, high risk, according to serum creatinine, the simplest way. If this lady has CKD and the creatinine is less than 1.5 milligram per deciliter, no proteinuria, high blood pressure is controlled, this is a low risk, and I can allow pregnancy safely, except in some diseases like lupus or reflux disease or some glomerulonephritis. If creatinine above 3.5, proteinuria is nephrotic, hypertension is uncontrolled, this is a very dangerous zone, and I advise here not to proceed for pregnancy. But if she is already pregnant, I should continue, although the risk is high for the obstetric and for the kidney. Between these two sides, it is gray zone. So I should individualize my decision according, she has babies before or not, what are the wishes, and my role is to explore the risk clearly to the lady. And the final decision is the lady decision. Just for the sake of time, I have just one question for my professors, Professor Fouda and Professor Said, regarding what are the best contraceptive methods in CKD, dialysis, and transplantation from the obstetric and from the nephrology point of view.
Yes, good question. We usually face, as I said, these patients usually deliver by section, and we counsel them during pregnancy. The best way is to have sterilization. I mean, we do tubal ligation if they have sufficient number of children. If they have successful renal transplant and they need another pregnancy, we just space by intrauterine contraceptive device. So if they still need another babies, we put the IUD, which goes okay. We usually avoid the hormones, which will be added another chemical to the already given immunosuppressant drugs. And works both way okay. But usually after the second cesarean or so, they ask for sterilization. I will go ahead with that one.
I can individualize the choice of the contraception. I can use oral contraception, except when we have a patient with systemic lupus, we have instance of hypercoagulable state, I will not use. I can use oral contraceptive because sometimes the risk of pregnancy is more than the risk of the oral contraception. I can use intrauterine device so long as there is no risk for bleeding. And tubal ligation, of course, as Professor Said said.
Because of the time, at the end of these two presentations and fruitful discussion, I appreciate the presence of my dear experts and Professor Salah Al-Hadi, the Dean of Mansoura Faculty of Medicine, and my Professor Ashraf Fouda for their nice presentation and a nice and fruitful discussion. Thank you very much. Now it is my pleasure and honor to introduce Professor Ashraf Fouda. Professor Ashraf is the Vice President of Mansoura University, and he is the past Dean of Mansoura Faculty of Medicine. And he did a lot for the Faculty of Medicine and for university. And above all,